Lung cancer is very common. It is the commonest cause of death due to a cancer in the UK. Unfortunately, most people who present with lung cancer present late, and as a result their mortality in the first year is very high. The risk factors of lung cancer are predominantly smoking. Over 85% of people who present with lung cancer will have been or are smokers. There are other risk factors to lung cancer, including exposure to things such as asbestos in the past, or people who work in smelting or foundries, or people who've been exposed to coal dust. The majority, however, it is a smoking-related disease. Patients can present in many different ways. Sometimes they can be just incidental findings. So, for example, they've had an X-ray or a CT scan for some other indication, and often those are picked up early.
Potential symptoms of lung cancer that warrant further investigation, usually a chest X-ray in the first instance, include such things as an unexplained cough, shortness of breath and chest pain, particularly in a patient who smokes or has in the past. And there are also a number of non-specific symptoms that might indicate lung cancer, such as unexplained fatigue, loss of weight and loss of appetite. It's important to note that NICE referral guidance for lung cancer differentiates between smokers and non-smokers, and recommendations do differ for these populations. So smokers presenting with one symptom of potential lung cancer should be offered an urgent chest X-ray, whereas non-smokers should present with 2 or more symptoms before an X-ray is offered. But an urgent 2-week referral for suspected lung cancer should be made in all patients over the age of 40 who present with hemoptysis, regardless of their smoking status.
Usually if somebody's got hemoptysis, coughing up blood, they will come straight away to see their GP or present to casualty. But that is one of the less common causes of people to present. It's more often that they're feeling non-specifically unwell, or they've had a change in their symptoms. Remember, many of these patients are smokers, so they might have COPD, and so they're used to coughing and used to being breathless. But it's the change of that symptom to being a different type of cough, or the breathlessness changing, that they should be looking out for. We also need to think about pneumonias. Patients with pneumonia can sometimes have an underlying lung cancer that's obstructing the airway, which causes the pneumonia. And so it's important whenever a patient has pneumonia that they have a follow-up X-ray to ensure it is cleared. Up to 40% of patients will be admitted to hospital before they get their diagnosis of lung cancer. So recognising a patient who's coming and seeing you more frequently is, I think, something as a general practitioner you should be alerted to and consider further investigations. A chest X-ray is the main diagnostic tool initially in general practice to make a diagnosis of lung cancer. And that can be a very helpful thing. It may show the cancer itself or may show complications of the cancer, such as a pleural effusion.
There are cases where the chest X-ray is reported as normal, but the patient does have lung cancer. Chest X-rays are not infallible when it comes to the diagnosis of lung cancer, and indeed false negatives are not uncommon. Chest X-rays can miss cancer due to a number of reasons. For example, where the tumour is located within the lung, or indeed the size of the cancer. And they often can't give a definitive diagnosis, as it's difficult sometimes to distinguish on a chest X-ray between lung cancer and other conditions which might appear on the chest X-ray. So we've had a number of cases of patients with advanced cancer presenting with a apparently normal chest X-ray. So it's important not to rely solely on the chest X-ray, but to develop an index of suspicion based on other tools such as weight loss, a change in symptoms, and indeed thrombocytosis has been shown to be associated with an underlying malignancy.
Most people who present with lung cancer are at stage 3 to 4, in other words, already advanced cancer. It's important that we get to treat these patients as soon as we can offer more treatments to people when they are less symptomatic and fit enough for treatment. There's also new treatments that are available to people, for example, the TKIs and some of the more novel treatments, which can really improve somebody's prognosis and how well they feel. So we do need to be referred these patients, even if they seem to be very advanced. And the sooner we can treat them, the better. On top of that, the sooner we see patients from when they first start their symptoms and are able to diagnose it at an earlier stage, so stage 1 or 2, the more likely we are to be able to offer them curative treatment. It's not just surgery, there are other treatments that are available for people with lung cancer. Stereotactic radiotherapy, radiofrequency ablation, for example, can be used in people with less good lung function, but early stage disease. So, important thing is, as soon as you think a patient may have lung cancer, that you refer them to your local chest clinic as a fast track on the 2-week wait, so that the consultant can see them and start them on the investigation and treatment process. When you refer your patient to a chest clinic, it's important that you enable the consultant to be able to request tests and get the patient through the pathway as quickly as possible. Supplying them with clinical information, such as symptoms and smoking, is the first thing that's important. Giving them other information, such as comorbidities, especially the presence of COPD or diabetes, can be helpful. Knowing what medications people may be on is also very important, in particular blood thinners and the presence of metformin. Metformin is important because if a patient is to have a CT scan with contrast, it has to be stopped at the time of the CT scan. It is also very helpful to have some up-to-date blood tests, and in particular to know the renal function or the estimated GFR enables the consultant to request a CT scan safely with contrast, as an eGFR of less than 30 means we cannot use contrast. Safety netting is important. A patient may present many times to a general practitioner before they get diagnosed. So if a patient is coming to you, do think, could this be cancer? Just because a chest X-ray is normal, do not discount cancer as a diagnosis. Just because they are a non-smoker, do not discount cancer as a diagnosis. Be alert to other symptoms, including fatigue and weight loss. Be alert to the blood tests, in particular the thrombocytosis, which has been shown to be a very high positive predictor.